Good afternoon. This is Larry Bird, and on behalf of 0 to 3 and the Quality Improvement Center for Research-Based Infant-Toddler Court Teams, I want to welcome you. And Dr. Baston is going to join us shortly. We're going to break the content out in the following format. First, spending a little time talking about how to engage parents with different types of use disorders, some thoughts on screening, early introduction into counseling, some ideas that are evidence-based compared to some myths, and some thoughts on treatment, particularly evidence-based interventions. So I'm at the North Dakota Fetal Alcohol Syndrome Center in the Department of Pediatrics, and Dr. Baston is at the Cooper Health Institute in New Jersey. So as we begin to think about this, we need to realize that in a foster care setting, the proportion of people who have substance use disorders is going to be very high. Identifying people with substance use disorders is best accomplished, most optimally accomplished, by a systematic strategy of screening. It's not productive, even though people have strong feelings about this, to believe we can identify people by looking at them. So we want early on a systematic program to identify substance use disorders in the parents, because often that's one of the key components here to activating appropriate intervention, getting parents back on a trajectory where they'll be able to accomplish reunification and development of a permanency plan. So Dr. Baston had provided a slide talking about a widely recognized, well-studied intervention called screening, brief intervention, referral to treatment. And the evidence here is really quite substantial. The goal of this is to identify people who have use patterns that are causing them problems. This is followed by a program of brief intervention where we use several techniques to help people clarify where they're at with their usage and to identify strategies to begin make these initial steps to recovery. And for a significant number of people, they need to be referred for more specialized long-term treatment programs. This is especially true for people whose pattern of use is causing them a lot of difficulty in their daily lives, or where it's affecting their health.
Thank you so much, Larry. This is Dr. Caitlin Baston. So thank you all, and I'm sorry I couldn't hear anyone and they couldn't hear me until now. So I could see, but just to catch up a little bit, the bottom line here is that people with substance use disorders look just like you and me, and it's really important that we use real tools and evidence-based tools to help people before it's really far down that line. This is true for parents, pregnant women, anybody that we might be interacting with. And so in the healthcare system, as Dr. Bird was pointing out, we really like to use what we call screening, brief intervention, and referral to treatment, where we're asking people in an evidence-based way, and that can be a questionnaire or it can be an in-person screening tool. And where we're headed here is that one of the recommended ways to do this is through the NIDA quick screen, which is a very, you can do it in a paper format or you can do it in a verbal format. And it's a validated way to go about asking people about alcohol and substance use. And this is really pointing at substance use that is non-prescription or taken not as prescribed. And it says here, it kind of shows the way that we do this in the healthcare system, where you're just saying, hey, I'd like to ask you a few questions that give me allow me to better take care of you medically. And I think one of the keys when we're doing this is that we're very open and that we really don't even show a whiff of judgment when we're asking people these questions. Because as you may imagine, people with substance use disorders or even just early substance use or substance misuse have a lot of guilt and shame around that because our society puts a lot of guilt and shame around substance use. One of the ways that I really like to do this is a validated questionnaire in pregnancy, but I actually approached many, many patients with this, which is the 4 Ps, and that's shown here. And the reason I really like this is because it backs into the issue without skirting around the issue. So I'm going to ask it in a non-judgmental way and leave it open for people to tell me things, but I am going to ask directly. So it says, did either of your parents or any of your parents have a problem with alcohol or other drugs? How about your partner? Does your partner struggle with alcohol or drugs? And how about in the past? Do you ever have difficulties in your life? And what about in the past month? So it comes to the issue of now, but also gives us a lot of other really important information. What is this person's life like? Who around them is struggling with substances? And you may learn a lot just because someone's partner is struggling. And then the other thing I always like to point out is that we as providers or first-line care providers may not be the first ones to notice. And a lot of times what happens in my line of work is that a family member or a friend comes to me and says, hey, I'm worried about my family. I'm worried about my friend. And that may happen in your field too. And the thing that I also like to point out, again, is that our judgment may be off. And so when you see signs like irritability or missing appointments or not showing up to things or even drowsiness, this could be substance use, and it's important to ask about it. It could also be mental illness. It could also be psychosocial stressors. Someone might be homeless. And so again, we really want to screen universally, which means we ask everyone. We don't judge who we're going to ask. We look at the population, and every single person gets asked in the same exact way. And if you see signs like this or a family member comes to you, then you can dig in even further. And again, I know I said this already, but it's really important that we're not afraid to talk about it and ask people directly and be really open. And in order to do that, we really need to use the right language. We need to say the right things. There's something that I find really helpful called a dictionary, which anybody could Google at any time. And it tells you basically yes and no words, as an example here. So when you're talking to someone about substance use, I always say things like substance use or substance use disorder, or I say, do you use alcohol or do you use other substances? I try to say things like you had a positive urine test or there was a test where this came up, as opposed to a dirty urine. And words that I always avoid are abuse or abuser. I avoid the word addict. Even if somebody says to me, Doc, I'm an addict, I'll say back to them, it sounds like you're struggling with substances right now. And it may seem odd to not use language that someone else is already using, but it's really important that I don't continue stigmatizing language. And one of the things that we see a lot right now with substance use disorders is people saying opioid replacement therapy or even sometimes medication-assisted treatment, which is a term that we use a lot. And we're actually trying to just even destigmatize from that, which is just to say this is medication to treat a substance use disorder. That medication in itself isn't a replacement of one thing from another. It's a medication that a physician or a provider is recommending for somebody, and that we know that it has really good evidence, and it's not the same as being addicted to something. And I always say this when I'm talking about talking to others with substance use, which is in healthcare, we have a saying that says, like in a code or an emergency situation, check your own pulse before you check the patient's pulse. And that's because if somebody is, in a dire emergency in front of you, but you are so upset that you're having a hard time focusing, you can't actually be really helpful. And it's the same thing emotionally. So if you are thinking about a parent or a mother or a pregnant woman using substances, you just go through a mental activity of picturing that in your mind, it can bring up a lot internally, and that's okay. I'm not saying to not have feelings about it. I'm saying to identify your feelings. It's really important that we figure out what things we're going to encounter that have caused emotions to evoke in us, so that when we're working with other people, we can do a really good job of addressing that and making sure that there's not a lot of what we call countertransference, or putting our emotions onto somebody else, or having your interaction be not the way you want it to go. Parents in general, whether it's a pregnant woman or a parenting woman or another parent, have a lot of shame and sometimes even denial or fear about their substance use and the way that it's going to affect their children. I think the reason this is really, really important to talk about is that sometimes when we're interacting with these parents, I think it's our own worry, like our own thoughts. How could you do this to your kid? Or don't you know this is terrible? And that might be going on in our minds. And we think, well, of course somebody wouldn't do this if they know it's bad for their kids. But the reality is that this really is a mental health disorder or disease. And the fact is that people know it's bad, and if they could stop, they would, but they can't. And there's a lot of shame involved in that. So parents who are using substances don't need to be told that they're terrible parents or that they're doing something horrible. They need to be told, you can do this, but you need help. Some other ways that parents might present is, don't worry, I'm totally fine. I'm never going to use again. I don't need any help. And that also worries me, because it's not that parents don't care, and of course they are committed, and of course they care about their kids. But sometimes if you're still not asking for help, that's a setup for failure, mainly because they care a lot and they want to get better, but if they could, they wouldn't be in this situation in the first place. So they really need help navigating that, and it doesn't make them weak, and it doesn't make them bad parents. So I think one of the best things we can do from here is really understand what the risks really are and which substances cause which risks, especially alcohol and things that are legal and prevalent in our society. And I think from here, Dr. Bird can take it and tell us a little bit more about this, because it'll really help us counsel parents appropriately.
So for many mothers, especially who are pregnant, one of the great fears is that they've done something during pregnancy which might have a long-term or negative impact on their child. And certainly with moms who have prenatal alcohol exposure, that's the case. In the United States, depending on the prevalence rate, we have about 106 new cases of fetal alcohol spectrum disorder born every day. That might be as high as 580 if the prevalence rate is about 5%. And that was a recent estimate published in the Journal of the American Medical Association. Before I go on, one of the things I'd like to point out is that as it currently stands, if there's 106 or 580 of these babies born every day in the United States, only 1 or 2% of them will ever be identified. The other 98, 99% will spend the rest of their life without a diagnosis of prenatal alcohol exposure or fetal alcohol spectrum disorder. And much of that time they'll be treated for the wrong thing, and that's going to have disastrous outcomes. People always ask about what's the barriers to identification of prenatal alcohol exposure or fetal alcohol spectrum disorder. And I think it's common, people say, well, I know a lot of women drink during pregnancy, it's just not the ones that I see. Second thing that's common, asking about drinking will complicate my relationship with my patient. And neither one of those are true. Alcohol use is pretty well distributed across the United States. In some places might be higher than others, but virtually all prenatal care providers, all pediatricians, all psychiatrists all people in juvenile corrections, foster care, substance use treatment programs see folks with a fetal alcohol spectrum disorder. As people are probably aware, there's a lot of concern now about the most recent epidemic, and this one's on opioids. And they believe that drugs are a bigger problem in their particular setting. So I think a helpful rule is to understand that for every case of neonatal withdrawal syndrome that we see, we probably have 7, maybe as many as 8 cases of fetal alcohol spectrum disorder. There's a common belief that we're already doing everything that needs to be done. This child has an IEP, maybe they're getting some kind of therapy, maybe they're on a medication. But I think this is a serious pitfall because this underestimates the future consequences for these children. FASD tends to increase in severity over time, mostly because it's undiagnosed and untreated. And lastly, people say, I just can't bring myself to put a label. It's just too much stigma both for the mother and the child. I think in FASD, it's important that we get a label so that we understand what we're treating. We can look ahead at the developmental course for these disorders and plan ahead. In our program, we screen using this single question, when was your last drink? We have this embedded into the medical record at every prenatal care site in the state of North Dakota. We use it in our clinic. And I like to have students understand that we don't like to ask more than one exposure question at a time. I think that just makes the conversation flow better and get you a more accurate picture. I've provided here a screening tool on screening for fetal alcohol spectrum disorder. It's a very straightforward, common sense tool. The PowerPoint's available here. If you'd like to have copies of this, you could send us a note and we'll be happy to send you copies. In fact, there's a little booklet, it's 4 pages, talks about the process and how you do it. But screening for fetal alcohol spectrum disorder is not complicated. Can be done by pediatricians, family practice doctors, psychiatrists, neurologists, in foster care, substance abuse settings, and juvenile corrections. And more importantly, should be done in those settings. A key to management of fetal alcohol spectrum disorder is to recognize that wherever we're at now, there are potentially preventable problems coming up on the horizon that if we can prevent them, will reduce the severity of the phenotype by a huge amount. And when you think of fetal alcohol spectrum disorder, you should think of this little exit sign here that gives us some guidance on things to be concerned about in the future. And if we identify these early, we prevent some of them, we make dramatic reductions in phenotype severity for these affected children, make it easier for their parents to parent them, and greatly increase the likelihood of reunification if they're in a foster care setting. Just a couple more comments about fetal alcohol spectrum disorder before I turn this back to Dr. Baston. I think it's important that we understand that prenatal alcohol exposure causes damage to the brain, and one of the areas of the brain that is damaged is the part of the brain that listens, understands, remembers. And so rather than repeatedly saying the same thing over and over again, we like to switch to picture schedules. And we have schedules for a whole bunch of things: bedtime, getting up in the morning, taking your medication, on and on. And I think these picture schedules are very, very useful and compensate for one of the main problems people with FASD have, and that's their ability to listen and to remember. I've put together a PowerPoint here of some of the key areas. And since we're running a little short of time, I don't want to go over all these, but I do want to point out the symbol in the middle. It's really crucial in prenatal alcohol exposure and in fetal alcohol spectrum disorder that you realize a person does not have to get that much better to do much better. The key is to understand, have the correct diagnosis, and to accommodate for these problems. When we begin to accommodate for these difficulties, if you have vision problems, you need glasses. We reduce the severity of these problems and the effect they have on a person's life. So I'll pass this on now to Dr. Baston.
Thank you so much, Dr. Bird. I think FASD is one of the most underdiagnosed things that we see. And in general, especially when we talk about perinatal exposure during pregnancy, alcohol is number one, the most common. Alcohol and nicotine are so common. And number two, actually has more long-term effects than a lot of other substance use disorders or substance exposures. And I think it's really important that we, number one, understand that in our society, because since alcohol is legal, a lot of times people think, well, alcohol must not be as bad as, cocaine. What if they're using cocaine? And the truth is that we have to look at the science and look at what is out there and know that, yes, we need to get help for people, and also we need to try to take stigma out of the question and really meet people where they are. A lot of people, when they think about managing substance use disorders, they picture this. They picture like a support group, an NA group, and the reality is that there are a lot of different treatments out there, and it's really hard to know what's good and what's not good, and that even though support groups and things like that sometimes are low barrier, there's still a lot of difficulty for people to get into treatment. There's fear of judgment and stigma. Just if somebody comes out as needing treatment, even for something like FASD, or parents, having to say, hey, I think my kid needs help, there's a lot of stigma and fear behind that. There's a lack of social supports. Sometimes there are members of a family that are really struggling, and yet people will hold that nuclear family together for a really long time and try to cover up problems that are happening rather than have somebody get help or separate while that person gets help. And then there's environment. There's poverty. There's a lot of systemic barriers to people getting help. And I want people from this webinar to know that not all treatment is good, and that for different substance use disorders, not all treatments are created equal and not all things are the same. So if you think about opioids, alcohol, and nicotine as one bucket, in that they all have evidence-based medications we can use to support people getting better. And in that means that we really should be tying in medical help for those disorders. Stimulants, PCP, marijuana, unfortunately, the science isn't where it is for those others. So it doesn't mean that we don't have treatments, but we don't have rock-solid medical treatments we can use. So our treatment really hinges on psychosocial therapy, environment, sober living, and a lot of behavioral supports. And then overlaying all of this, regardless of the bucket, is treatment of co-occurring mental health disorders, and in general, working on the psychosocial and environmental factors that people struggle with. For the ones that are in that left side bucket, opioids, alcohol, and nicotine, we really want to use the treatment we have and use it because it really changes outcomes. For pregnant and parenting women, there was actually a national guideline published this year, the clinical guidance for treating pregnant and parenting women with opioid use disorder and their infants. And there was an ACOG, or American College of Obstetrics and Gynecology, committee opinion, which is their big statement about what gynecologists and obstetricians are standing by right now as far as the evidence. And they say basically opioid agonist pharmacotherapy is recommended. So that's what we're talking about when we say medical treatment for opioid use disorder. There are two that are recommended in pregnancy, which is buprenorphine and methadone. And then we recommend that over withdrawal. NAS does occur when people are on those medications, not 100% of the time, and depending on the environment, sometimes it's as low, now we know it's even 14%, which was what was shown in a new Yale study. But that in general, this is treatable, and we shouldn't keep women from getting the treatment they need to keep them and their baby safe in pregnancy for fear of NAS, which is a treatable condition. Withdrawal, on the other hand, if we're tapering people or just putting them through detox, is associated with really high relapse rates and worse outcomes for moms and babies. So that means that higher preterm labor rates, higher infection rates, and a lot of complications that come with that. So we really want to at least offer women the gold standard of treatment who have opioid use disorder. And this is just to show this study, which I've pointed out in some other talks, basically said that the one on the left, this graph you're seeing, was one of the first studies they used when they were looking at buprenorphine, which is Subutex or Suboxone brand named. They were looking at putting people on that medication versus tapering them off. And this was a double-blind randomized control trial, which basically means people didn't know whether they were getting this medicine or getting placebo or a sugar pill, and the scientists didn't know either. And they randomized people to getting one or the other. And when they looked at what happened with treatment retention, the people who got the medicine and stayed on the medicine were much more likely to stay in treatment over the course of a year. And the ones who were tapered off of the medicine, none of them stayed in treatment, and 4 people died. 4 people overdosed and died. And the reason I point that out is that we know opioid use disorder right now is one of the major use disorders that has a very high mortality, or people die from this, and at a young age and quickly. And if we have a medicine to keep parents and mothers alive, we should definitely offer it to them. And just like Dr. Bird said, substance use disorders and, people long-term who've struggled with mental health and substance use, this is a chronic disease, and we have to walk this path with patients. So it's a long-term path. People are going to have good times and less good times, just like diabetes, just like hypertension, just like asthma and other things that I treat in general primary care. Substance use disorders are something that I follow for their whole lives. And actually, even though people think of substance use disorders as really, really hard to treat and that people go back to use or return to use often, the truth is that asthma and hypertension are harder to treat. And people have asthma attacks even after treatment, or have really high episodes of high blood pressure even after treatment, more often than people with substance use do. So we're going to treat it long term, and we're going to get people into good therapy. And I want you to know that in general, we don't just say be empathetic because it's the right thing to do. We say it because it's evidence-based. And this is a big part of trying to find what good therapies are in your community. This was a study that basically showed when they looked at what they call Rogerian skill or Rogerian functioning, it's a measurement of a therapist's empathy levels. And therapists that had higher empathy levels had higher treatment retention rates for their clients. And this was a study on alcohol. Their clients actually had less drinking than those who had therapists who were less empathetic. So my final things I'll leave you with are 3 things to look for in a good treatment program in your community. Number 1 is, do they offer medication? And that's important to know just from a philosophical standpoint. Are they going to support people if they need medication? Number 2 is, do they have experience with mothers and parents? They're very unique needs of parents. They need childcare. They need specific parenting support. Sometimes they need family and parenting counseling and education. Also, they often work with child protective services, or they have involvement with child protective services. And so it's really important that treatment programs that we send parents to are versed in those things. And number 3, do they offer co-occurring mental health? This can come in a variety of forms, but do they have a psychiatrist or psychologist on site? Do they refer to people? And what kind of treatment do they use? Can they use evidence-based things like CBT or DBT? It's really important to know if they're using 12-step facilitation or just referring people to NA and AA. If they have special things that are able to talk to what they do with people who are on medicine, because a lot of times AA and NA do not support patients being on medicine. So in general, when we're reaching this population, number 1, we really want to engage them. And that means using destigmatizing language, knowing what to say and not being afraid to talk about this, and making sure that we're not picking and choosing from our own judgment who we're going to ask about this, that we're putting out things right now and that is a public health initiative that is universal screening, whether we're doing this in schools, whether we're doing this in healthcare offices, anywhere that we may be interacting with patients, that we do it for people who have substance use disorders. We do it for every single person in that setting. That we're prepared to counsel appropriately, so that means that we understand what the real risks are of substances and understand which ones have treatment and what treatment we have for each one of those things. So like Dr. Bird was talking about, we have great supports and treatment and screening tools for people whose kids may have FASD, and for who adults may have been struggling with FASD their whole lives and had it undiagnosed. We have excellent treatment for substance use disorders, especially medication-assisted treatment for opioid, alcohol, and nicotine dependence. And we really want to know what treatment programs in our communities are the ones that you would want to refer people to, because they're not all created equal. So I hope in our brief webinar we were able to address some questions that you might have had, but I'm happy to open this for myself and Dr. Bird to more questions that you have out there.
Dr. Baston, one of the questions I have is, how important do you think it is that when people come to see you, the initial contact in your waiting room and your front office is in ensuring overall success to your program?
Thank you so much for that question, Dr. Bird. I think that what I call my frontline staff, which are my medical assistants and my front desk and my health coach or health navigator, are actually the most important part of my program. I teach each of them, and we have staff trainings that we need to, number one, make sure that we're engaging in an absolutely open-armed and friendly way. We have what we call a low-barrier clinic, which means somebody can walk in at any time, and that means they can walk in any state. And it's really important that people feel comfortable doing that and that they can continue to do that so that they can get treatment and care. And my staff is all trained in what we call seeking safety. It's one method of trauma-informed care. Basically, is teaching people who have had trauma in their lives how to live in the present and helping patients to navigate when they're being triggered or having really, really hard time with trauma or reliving trauma they've experienced. Our treatment program has a really high retention rate, and I think that's because people aren't afraid to keep coming back in because of the engagement, the friendliness, and the openness of every single one of the people in my office. The program that I'm running right now for pregnant women and parenting women, their perinatal substance use disorder program, currently has a 92% treatment retention rate.
When you're seeing people in your program and going to follow up over the longer term, how do you share with them the idea that this might not be short term, this is something we're going to work towards over a long time, and that there may in fact be occasions where you have relapses? Can you fill us in a little bit on how you share that information?
Definitely, and I think the more challenging answer to that is that I approach it differently with different patients. It really depends on where somebody is when they're coming to talk to me about it. Some people are really afraid when I say, hey, this is something that you're going to have to work on for the rest of your life. And that can sound really overwhelming to people. And the same exact thing happened when I was just doing general primary care. So if I diagnose somebody with diabetes, and we talk about having to start medicine, that's so overwhelming and scary for a lot of people. They don't want to take a medicine every day. They don't want to have to deal with diabetes for the rest of their lives. It's really hard to have to change your diet your whole life and to worry about this and all the medical complications that come from that. And so I just like to really meet people where they are and talk to them about the fact that it takes a period of change and time for people to really wrap their head around what it means to have a chronic disease or chronic illness. When people come into my clinic, there are a couple different ways that people approach this. And one is some of my patients have been already struggling with this for more than a decade, and they know it's going to be a long time, and they know that they're going to have to keep working on it. And I just tell every single person, I don't care what state you're in. I don't, no matter what's happening in your life, we're going to be here for the ups, the downs, the good days, the bad days. And in our clinic, you never get in trouble for anything that's going on in your life. So if you're struggling, if there's social problems, if this is going on, you can always walk through these doors. This is a safe place. So I tell everybody that. I tell everybody they can always come back. Once a patient, always a patient. We don't discharge people. We tell them that we might refer them to a higher level of care or get more support than what we can offer them, but that doesn't preclude them from coming into our office as well, so they can always continue to come back. And if they need help or something isn't going well, they can always walk through our doors. I think that's the most important message that we send people. And when I have young people or other people who are very scared of thinking of this as a chronic illness, I just say, we're going to take this one day at a time, but I want you to know that no matter what is happening in your life, you can always come in here.
So Celeste asked a question about the name of the treatment retention study. Could you share that with her?
I see that question. I'm going to look it up and give you the reference so that you have the exact reference of that. And I imagine, Celeste, that you're talking about the early buprenorphine randomized control trial. So that's the one I'll send you. If that's not correct, please let me know, and I'll send you what you want.
As Dr. Baston mentioned, a key to this, I think, is helping people understand that, like so many conditions, asthma, diabetes, epilepsy, hypertension, this is a long-term treatment program. And one of the unique things about fetal alcohol spectrum disorders is that at the same time we're trying to treat the parents for their substance use problems, we're also trying to treat the child for a full range of learning and behavior problems. And so I think this actually complicates the treatment of substance use disorders in people who have children with FASD. And one of the keys to this, I think, is to understand that undiagnosed and untreated, the outcomes are poor. They're especially poor for the mothers. Many of these moms themselves will have had fetal alcohol spectrum disorder or prenatal alcohol exposure. Sometimes you'll encounter a family where there will be several people who are affected by this. And if we're not aware of this, then I don't think we can provide the appropriate intervention. We tend to err on the side of too much complexity, too fast, and if we know that they may have had exposure to alcohol or have a fetal alcohol spectrum disorder themselves, then we can slow this down, provide appropriate accommodations and support for them in the long-term encouragement that's needed. And I think that really makes a big difference. So I have a question for Dr. Baston. We hear two common concerns that come up. One is people say, look, you're just trading addiction to one drug for dependency on another when you do this medically assisted treatment. And the second, and I think you kind of addressed this earlier, is the key is just to suck it up and quit. Could you respond to those two?
Yeah, I can. So when I I hear people say we're treating one addiction for another. I always say that what happens, the core misunderstanding here is what is an addiction or a substance use disorder that's different from a dependence on a substance. And that's that somebody has a substance use disorder or an addiction, that means that they are unable to control the way that they're taking a substance. It's affecting their lives negatively, meaning that they are having issues in school or with their family or their work. They're losing their housing. They're maybe losing their lives. So they're doing things that are having a huge negative impact on their health. They might even overdose repeated times. And when the difference between that and a physical dependence is that somebody can have a physical dependence on something, which just means that if they don't have that, they get sick. And when they have it, they feel normal or stable. That's very different from having a substance use disorder. And what the medicines that we have to treat substance use or treat opioid use disorder specifically, the medicines that we have stabilize the brain, and while 2 of the 3 of them cause a physical dependence, that's very different from an addiction. And so taking a patient who has a severe life-threatening disease, there's a substance use disorder, meaning that they could die and that they're losing their lives and their families and everything, and giving them a medicine that stabilizes their brain and that allows them to live safe and productive and full lives, that is what we're doing when we give somebody a medicine. So there's no trade there. It's a no-brainer to me. That means I'm taking somebody who is at risk of death and giving them something that might help them to live, and not only live, but have a life that they deserve to live. So family, love, a job, integration into society. So it's not at all, if anything, it's a very, very good change, or if some people say trade. So that's how I really look at that, and that when people say like there's something wrong or you just have to suck it up and quit, when somebody has a very severe neurologic change, which happens after you've been developed a use disorder, we know that there's brain science behind this, right? So parts of your brain are changed over time being exposed to substances. And when enough of those changes occur, somebody has a full clinical picture of a use disorder or a severe use disorder. And the brains don't heal overnight, and that taking the substance out and not using the medical treatments that we have for this means that people are at risk of death and overdose. So there's no sucking it up here, just like I don't say to my patients with diabetes, like, just suck it up and stop having diabetes. They can't control what's happening in their pancreas, and my patients with severe substance use disorder cannot control what's happening in their brain because there are neurologic, physical changes that have happened, and we need to, in this case, we have medicine, not in all substances, but in opioid use disorder and even with alcohol, we have medicines that really help address those changes and stabilize people, and so that's why we want to use them.
A common concern I hear from substance treatment providers is that most of the treatment failures, most of the relapses, treatment failure, I think is a poor term, occur because people aren't committed to this. One of the things I like to point out to them is that there's much more to treating a substance use disorder than sheer willpower and commitment. And much of the time, I think treatment success is poor because we're accessing relatively poor treatment programs. They're poorly designed, poorly staffed, they have a poor outcome model set up, they're not using evidence-based interventions, and so when people don't do well, rather than changing the treatment protocol that they're using, they tend to accept that and conclude that the problem is the person who's seeking treatment. Do you have a thought on that?
I do, and that's, again, I would just point back to that slide where we looked at all the chronic diseases and how often people, quote unquote, relapse, or how often people, have an issue with their treatment regimen, and that chronic diseases, lifelong illnesses that people live with, are challenging for so many different reasons. It can be that people have an issue getting their medication. It can be that other things happen in their lives that change their basic disease state. So somebody with asthma might have been controlled, and then they move into a home that has a lot of mold, and then all of a sudden it's not controlled anymore. There can be environmental factors, and other things. And we don't say to that person with asthma, you're a horrible person because you started having asthma attacks again. When you look at somebody with diabetes, they may have overall an incredible control of their diabetes, and that doesn't mean that every once in a while they don't have a blood sugar of 300 because something happened. One of my friends that has type 1 diabetes just had an issue with his insulin pump. It got disconnected, and he didn't know, and he ended up in DKA. So in a very similar way, I have patients who are well controlled for a really long time, and then something happens environmentally, and they're put in a situation that immediately triggers them, or they go right back to where they used to be. It can be a trauma trigger. It can be something else. It can be mental health. It can be environment. They lose their housing. They end up homeless. I've had a patient who was stable for a year and then ended up homeless. And in that situation, they ended up going back to use or returning to use. And then that person immediately came into the clinic, got right back in, and did continue to do amazingly well. And so when I talk to patients about it, I say, you don't start at ground zero after that happens. It's not like you don't have all that sober time, or that we're hitting a reset button somehow. If you had something that happened to you, or you used one time, it doesn't mean that you're not still somebody who has all of this wonderful sober time and can continue to have wonderful sober time.
We're nearing the end, and I see we've got a couple more questions. Judge Connie Cohen has a question about access to care, especially medication-assisted treatment. And Dr. Baston, can you answer those last two questions as we conclude?
Yes. Thank you so much, Dr. Bird. I see access to medication-assisted treatment is inadequate. What should we know about that? Mainly that nationally, when they do studies of how much medication-assisted treatment there is compared to the need, there's a huge, devastating gap. We're working on it. I know that there's funding nationally, but a lot of the funding doesn't always go to medication-assisted treatment, and so we're making sure that there's enough of that. More than knowing that there's a lack, and that even in your own community, when you're looking for treatment programs, it can be really hard, or there can be wait lists. It's really important that if you're having trouble getting people in, that you can talk to some, you can talk to people locally, you can talk to people politically, and see if you can help us with that. And that also, it's really important to find a good medication-assisted treatment provider in your community, which is not always easy. The other question says, what is recommended for somebody who's not technically diagnosed with a substance use disorder but has an issue with substance, or it's negatively impacting their lives? So it doesn't take that much to get diagnosed with a substance use disorder. If your substance use is negatively impacting your parenting, you probably have a substance use disorder. You may not need the same level of treatment as my patient who overdosed 173 times, which I've seen. So that person with a mild substance use disorder, one of the reasons that I think it's really important that primary care doctors get trained and we have lower barrier access is that person hopefully will be caught earlier and can get help from their primary care doctor, get help from somebody right away, go into therapy, and if they need medicine, be on medicine, and that person's brain may heal or may be in a different place sooner. So I would say that's a perfect example of somebody who we should catch with SBIRT, or screening, brief intervention, referral to treatment, and who we should get into a primary care provider or somebody else as soon as possible. And I just put in here, I'm trying to make sure that I can post it, the reference to the study that somebody asked me for. and we can see if everyone can see that. It's a randomized placebo-controlled trial, and again, it was one of the early trials that they looked at when they were looking at buprenorphine and whether they were going to make it legal and available in our country. This study had such a great impact that you could not actually ethically repeat it as a randomized double-blind trial again. You would have to do an open-label trial so that people knew what they were doing, and you'd have to do a lot of ethical counseling or do something else if you couldn't have people just on buprenorphine versus placebo ever again because of the results of this trial.
Looks like our time is up. Thank you so much for joining us. Dr. Baston, as always, it was a pleasure.
Thank you so much, Dr. Bird, and thank you everyone for listening, and thank you, Dr. Bird, for helping with the technological issues we had in the beginning and for holding it down. So it was a great pleasure.